we wanted to take the opportunity to talk a little bit more about the living with your MPN. We could actually make an entire education day out of this topic, but we've skimmed it right down to the time we've got a little bit of extra time. So do forgive us for skimming the surface, but happy to talk to you afterwards. And hopefully it will just give you some ideas on how you can best help yourself. So, in the olden days, when my grandmother was a nurse, medicine was very much about medical management. It was about the body, it was about your blood results, have some tablets, and very much, well, what is the matter with you? Well, let's see what we can do. The culture's changed over the years now, and we're much more about what is it that actually matters to you. We know what's wrong with you, but that might not be the thing that matters to you. And we're very much trying to looking at you as a patient, as a person, as opposed to a body and the problem. We're trying to give personalised care, and by personalising care, you're enabling you to try and live with the condition that you have. Now, there's a lot of people out there with chronic long-term conditions, and what you find is there seems to be a process and a cycle that people go through. Now, I've shamelessly borrowed this from Crohn's because I think it's a really good illustration of the way of the path and the processes that people go to from diagnosis. And I'd like to think that all of you can look at it and think, yeah, actually there's a bit there that associates to me. And I think this process tends to be gone through at various stages in your condition. It's not just when you're diagnosed, but also at various other stages when maybe the treatment's not working, we have to change it. And yet again, things have changed and we've given you a bit of a shock and the carpet's been taken from you. And then it's about climbing the stairs and finding your way back and learning a new path, because things will never be the same as they were. But that doesn't mean that you can't live and you can't live life. And we quite often say to our patients, you've got this condition, you've got this diagnosis, don't let it be here, don't let it rule your life. You need to have it sitting here next to you. You can bring it out every so often and you can carry it around with you, but it shouldn't be the first thing that you think of every day, okay? And I think that's really important. And the way that we can self-manage and the way that we go through this is very different for everybody. We all come from different social backgrounds, different ethnic backgrounds, different beliefs, and we do have different family situations as well. So we all do this in different ways. And it's very much a partnership between the healthcare professionals, the doctors, the nurses, physiotherapists, pharmacists. There's a whole team out there to help you to climb up those stairs and develop the new path. But I will say sometimes the path isn't always a new smooth path. It might be a little rocky with a few stones in it. But again, we're trying to be there to help you. So what is self-management? Self-management isn't you going off doing your own thing and not ever seeing us. Self-management is more of an approach that you can use, but it's also a partnership between the medical team, the nursing team, the other healthcare professionals, and you, basically, to try and optimise your living with your condition. Okay. So this is one definition. Now, I think the Macmillan actually have a better definition, but you have to bear in mind that the Macmillan's definition is created for people that are surviving cancer, and their definition of surviving cancer is someone that's been through treatment and they've come out the other side, so they're living having survived their cancer treatment. An awareness and active participation by the person. Now, I've put in brackets in the recovery because that's a bit more of the survivorship side of cancer, but then to minimise the consequences of treatment, promote survival and health and well-being. And I think really that's really what we're trying to achieve with you. There was a systematic review of the evidence of self-management. Now, there are a lot of self-management courses out there, and a lot of breast cancer do one, Macmillan have one, and a lot of long-term other chronic diseases like diabetes, cardiac disease. They all have self-management programs that patients can go on to help get themselves on that path to recovery or their path to living. And they looked at all the evidence, really, and they've summarised it quite nicely in this slide, really, and I've just highlighted the key words, really. So it's very much about making sure you can play a more active role in managing your own conditions. It's a partnership, okay? It's not just about us telling you what to do anymore, okay? Sometimes it does mean that you have to make difficult lifestyle changes from something as not quite so simple as giving up smoking, which, is not everyone wants to do. Oh, what happened there? to actually maybe having to cut down on your work hours to try and optimise, the way that you're feeling. So it's about working with you to try and look at how we can change things for you to be able to continue living with it here and not right in front of you. Okay. It's about us helping you and providing you with the knowledge, the skills and the confidence to be able to manage not only your long-term health conditions, but also the practical and emotional impact that it have on your lives. So this is not just about physical and symptoms, it is also about very much the social side and your family and financial side as well. Okay. And they feel that when this happens, people can enjoy life more. You have a bit more control. They say that you have less pain, but also improve clinical outcomes, and you use the healthcare services less. There's various topics that are used in self-management programs, and as I said, we could make an entire educational day out of these using each of these topics. But just as an example, what we've tried to do is funnel it down, and we're going to focus on managing your symptoms. And what we're going to do is actually Claire's going to talk about some of the symptoms. We're going to ask Toby Alexander to come and talk about your perception of fatigue. And then we're going to just open the floor up to see if we can share some of your ways of how you manage the symptoms that maybe other people can be able to take away with them, help to self-manage their symptoms as well.
So firstly, how does this ring for many of you sitting out there? You go to your consult, you're told your bloods are great, off you go. And you're left feeling, well, actually, I don't feel so great. What we can see from studies, and has already been mentioned, is that MPNs are associated with a substantial disease burden that can affect your quality of life. However, until recently, there were few published reports that explored the patient's perception of how their MPN and symptoms affect their life and their work. The US MPN Landmark Survey was the first observational study to evaluate the impact of an MPN and patient-reported symptoms on overall health and productivity. So to see how this worked for patients outside of the USA, the global MPN Landmark study was conducted, and it surveyed both patients and physicians through a set of questions that weren't linked. So it wasn't a patient from one site and a clinician from one site. What we saw from the study was that most patients had experienced a symptom over the last 12 months that was related to their MPN. The majority of patients experienced a reduction in their quality of life secondary to their MPN symptoms. However, it wasn't only seen in patients who had high symptom burden, but those who had few symptoms as well. And it's important to remember it's not just the physical symptoms, but also the emotional effects of having an MPN, the anxiety that is caused. 89% of patients reported the worry that their condition was going to get worse, living with that constant worry. This slide just shows you some of the symptoms that was reported. It's a bit small, so I apologise, but right up the top is fatigue. It was the most commonly reported symptom, and it was the most severe symptom. And it was also the symptom that most patients wanted resolved. The results of the global study matched that of the US study. What the study also said to us was that there was a need for a proactive and standardised symptom assessment, which could be done at diagnosis and throughout the disease and their treatments. The MPN-10, which you can see here, is an abbreviated version of a much larger tool, but it's quick to complete for patients and you can do it independently. But it helps you to track your symptoms. It contains the 10 most relevant symptoms that we feel patients experience, and you can complete it once a week, twice a week to monitor how your symptoms are doing. Also, it's good when you start a treatment to monitor how your symptoms are responding to the treatment. But what it also does is allow you a tool that you can take to your consults with you to help guide your consults and to help explain to your medical team what it is that's really problematic for you. There's also an app that you can have on your phones for those that like Wizzy devices. It downloads onto your own device and then you can actually share it and email it to your medical team. So, given the complexity of each symptom, it's best to that we approach it in an integrated way. And it covers all concepts of health and well-being. So it involves diet, exercise, reducing stress, psychology and spiritual. We're going to focus on just a couple of symptoms and invite you to share with us, as Yvonne said, how you manage some of these symptoms. So fatigue. First of all, we'd like to invite Toby down. Toby is an MPN patient who has done some work looking at what patients say fatigue is.
So thank you for inviting me to speak this morning, and thanks in particular to Claire and Yvonne for generously inviting me to intrude in their session. So my name is Toby Alexander. 7 years ago, I was diagnosed quite by chance with an unclassified MPN, most likely ET. A second bone marrow biopsy a few years later revised the diagnosis to PV. I had regular venisections, but when my platelet count hit 1,700, starting hydroxy became a no-brainer, and my numbers have tumbled. And as you can imagine, it's been an interesting journey so far. As an MPNer, I came across the MPN forum on Health Unlocked. The latter describes itself as the world's largest online social network for health and claims to have 1 million+ members worldwide. The MPN forum, which was launched in 2012, is managed by MPN Voice, which, as you know, is the patient charity set up by the team at Guy's, who are hosting today's event. The online forum is visited by 15,000 people each month from across the globe and has getting on for 5,000 members and over 6,500 posts to date. What struck me reading the posts was first how often the subject of fatigue was raised, and second, the commonality of the language used to describe the experience of fatigue. Not only did many of the comments resonate with me, but my background is as a writer, so I'm particularly intrigued by the business of language. And I thought it would be a really interesting avenue to explore, but quite frankly, I was way too tired to even suggest it. Well, the hydroxy kicked in, and here we are. So, what do we know about fatigue and the impact it has on the lives of people like us with MPNs? According to the Landmark survey, which we've mentioned, but I'll say it again, which, as you know, was authored by Professors Claire Harrison and Ruben Messer and other people, the evidence suggests that the overwhelming majority of MPNs believe that their symptoms reduce their life quality. And the most frequent and severe symptom, as we know, that's cited is fatigue. And when asked which symptom they would most like to have resolved, most patients referred to an improvement in fatigue and tiredness, so it's right up there. But what is the real life lived experience behind the statistics? And how might such insights help deliver a better patient experience and alleviate the very significant impact of fatigue on patients' life quality? So using the MPN forum on Health Unlocked, I searched on one term, fatigue, but I drilled down through the 7 years of posts. I then extracted those comments which directly described the experience of fatigue, and then edited those down to around 11,000 words of relatable, anonymized quotes from over 150 individuals. So, it's ringing bells. Today, given the tight time constraints and the breadth of material the project has revealed, I'm going to give you just the briefest glimpse into what is an extremely rich theme of patient experience. I'm sure much of it will resonate with you, just as it does with me, but I hope it might also invite you to gain new perspectives and perhaps too some new vocabulary with which to describe your own experiences. I'm going to put up a series of slides with quotes, but please don't panic if you can't read all the words in all the quotes in the short time that they're going to be up there. You'll get the gist, and we will disseminate the material in other forms in the coming months. 3 broad themes emerge from the research. First, the totality of the fatigue experience. Second, the randomness of the fatigue episodes. And third, the all-pervasive impact of fatigue on patients' lives. Inevitably, all 3 are interrelated and nuanced, and binding them all is the issue of mental health. Identity, self-belief, mood, and unsurprisingly depression are inextricably linked to the experience of fatigue. Today I'm going to focus on the first two of these themes and also look at what MPNers say about the frustrations and management of fatigue in general. So yesterday when I spoke at the doctors' conference, I began by clearing up what I meant by fatigue. My tired was not necessarily their tired. There's no need for that today, other than to say that what frustrates many MPNers is that normal people just don't get it. So the first theme that emerges from the material is the totality of the fatigue experience, the whole body enervation, the complete mental and physical exhaustion. In describing what fatigue feels like, there is a diverse vocabulary, but there are common groups of metaphors and similes. Cement, both setting and set, is popular, as are viscous liquids such as treacle, and zombies crop up quite a bit, along with narcolepsy. There are juices of various kinds, including batteries, and as we'll see later, switches feature large. But while this starts to convey what fatigue feels like in the moment, it only hints at the reality of the whole fatigue experience. What is crucial to understand is how and when fatigue occurs, which brings me to our second broad theme, the randomness of the fatigue episodes. Fatigue that strikes out of nowhere, that follows no pattern, that brings good days that are a gift, and bad days that mean you just have to wait it out. But this is only part of the randomness story. Fatigue is fickle. So the real issue here is not simply about good days and bad days, but about feeling great one minute and zombified the next. It's what one poster calls their fatigue bombs, and it is such a perfect description. I'm going to read out the next quote that I put up so you can take a break from multitasking, because I think it nicely sums up our second broad theme. The poster identifies herself elsewhere as a busy mum in her late 30s. Just wondered if others suddenly get hit by this wall of fatigue. Yesterday afternoon I was peeling veg for dinner and suddenly was overcome with tiredness to the point where I almost went to lay down. It is never the same time of day or doing the same things. Sometimes it happens when I'm driving, but it is quite an overwhelming feeling. So what's the collateral damage of the fatigue bomb and fatigue in general, the all-pervasive impact on patients' lives? There's a huge amount of material on the impact of fatigue on patients' social and work lives, particularly on the latter, on the hours we work or no longer work, the career paths we follow or have to change, the day-to-day struggle to put in the hours, get the job done, and not embarrass ourselves when the brain fog descends. But that's a separate presentation. Let's look at mental health, since it underpins just about everything when we talk about MPNs and fatigue. So here we have a selection of quotes that illustrate, I guess, what might be considered the existential impact. Who am I? I'm not the person I used to be. I'm not the person I want to be. I've put these quotes up to illustrate the conversation about the interrelationship between the disease, fatigue, and depression. 3 different voices, 3 different takes, but a consensus on an indivisible and complex relationship. And lastly, I just want to highlight one other element of MPN's fatigue and mental health. I think this collection of quotes might loosely be called beating yourself up. They highlight a very commonly expressed series of anxieties. No one really gets this. They think I'm lazy. I think I'm lazy. I feel guilty. and the fact that while resting might be boring, fatigue can often lead to social isolation. And these are closely allied to concerns that about MPNs being essentially invisible diseases. You can't put an MPN in a plaster cast. And these anxieties and concerns are often exacerbated by the sense that symptoms are not validated, or even worse, invalidated. And this is particularly true when patients talk about their experiences with haematologists. They talk a lot about their patient experiences with haematologists. As one poster said, sometimes visiting a haematologist can really mess with your head. This exchange expresses the nub of the problem. Not only is a clinician's denial that fatigue is not a symptom of MPNs, regardless of blood counts, misleading, but it negates the patient's experience, and the effect can be profoundly damaging. Patients wonder whether their symptoms are all in their head, or if they're being a bit of a drama queen. If your haematologist, nurse, or GP invalidates your fatigue, then how on earth are you supposed to engage the support of your family, friends, or work colleagues? So how do patients say they manage the ups and downs of fatigue? Again, I'll read the next quote so you can take a break. Today was an up day, but I think I've overdone it. After such a ghastly day yesterday, I was overexcited to feel well. I've done lots of things, running about like a teenager, but now I'm home, flaked out on the sofa. Must learn to pace myself. For me, this quote sums up a lot of the themes in this particular conversation. The frustration of feeling fatigued and not being able to get on with life, the ghastly day. The joy and excitement of waking up feeling good, resulting in the desire to rush around and get everything done that you couldn't on the ghastly day. And then inevitably feeling completely wrung out and heading for another dose of zombification. The poster captures the push me, pull me, pace me tension that is at the heart of fatigue management. Posters are acutely aware of the consequences of overdoing it, but being aware of the pitfalls and actually ensuring you avoid the pitfalls is complex. So here we have a taste of the frustration of feeling fatigued and the desire to push through it and the fallout from that. And while acceptance, pacing, and resting might be the sensible things to do, as the first poster says, it's complicated, emotive, and it's tough. There are only so many hours in the day. So that's just the briefest glimpse into the material. Our next step is to consider what new conversations these insights might generate. We're exploring this with our community of clinicians, but it's really important to hear from you. What new conversations would you like to create, and with whom? How can we disseminate this material, and in what form? I'm going to leave you with this. Thank you.
So what a brilliant talk from Toby, and giving us a real insight into how as patients you are feeling and reporting fatigue. What we do know is that there are many things that contribute to fatigue, and that fatigue varies, as Toby said. And it is a complex symptom, and it impacts on many aspects of your daily life, not just the fatigue physical. Some days physically you feel great and I can conquer the world, but actually it's that mental fatigue of, well, actually no. So what we want to know from you now is, what do you do to manage your fatigue?
On a good day, I just get on with things. On a day when I'm feeling like that, I would recommend, if you like tennis, Amazon Prime. There is tennis on every day, practically, of the year. You can watch it on top of your bed, take a coffee up, and really just think, I'm so lucky to be able to do this.
Thank you.
Hello. I have found something which helps with both my mental health as well as the fatigue is to try and follow about 70% of the time an anti-inflammatory diet. I looked at I know the nutrient study is ongoing at the moment, and at one point the diet was listed online and I took it down from there and have adapted it because I'm vegetarian. But I do find that particularly trying to avoid sugar can help. I don't do that 100% of the time. It's impossible, but I do find it useful.
Hi, my name's Joy Bardi. I'm a complementary therapist and I'm an acupuncturist. I just wanted to share one thing that sort of might be really relevant for people. I published a paper called Legitimising Fatigue. Although it was with breast cancer patients, it's actually a lot of the symptoms. There's a lot of parallels for people. So I can actually give the reference to somebody later on or anybody that asks me. And it's sort of using it's coping with fatigue. There's a Macmillan booklet that's actually quite helpful and gives loads of tips. But a lot of the comments from the patients were very similar to what we've talked about today. I've also been involved doing studies with breast cancer patients, doing acupuncture, and that's alleviated the fatigue. It's reduced the hot flushes and made them more manageable, and it's helped reduce stress and anxiety and depression and improve quality of life. And this is another paper that I've been involved with that we've actually published results. And it was all linked to the fatigue was a result of the chemotherapy. And some of the patients had actually had it 5 years post-treatment. So the concept of living with and beyond, some of the symptoms don't resolve, so even many years after.
Hello, yes, mine's going to be a bit shorter than that one. My name's Tom Johnston. I was diagnosed with ET last year. My way of dealing with fatigue is rest and sleep. However, I've got a live-in motivator who gets my ass in gear.
So just some of the points that we thought we might mention. Perhaps the first step might be to understand how your fatigue is affecting you. Now, it might compound the fatigue, but perhaps keeping a journal or a diary that you can work out when the fatigue is most prevalent. We've already heard that actually sometimes there is no predisposing factors that make you feel fatigued, but keeping that diary that you can then discuss with your clinical team, your nurses, so that we can try and help you with managing it. For some trusts, there you have OT and physio supports where our own trust, they will do group sessions, individual sessions where they will look at your fatigue, help you work out how to manage it. There might be exercise classes, or I prefer to say physical activity. There may be group sessions where you can work with others in picking up tools to help manage. What is important to you? What are your goals for the day? Sometimes we might have to forget about the ironing to do something that actually we want to do and that we might enjoy. We speak about, you can't constantly take from the bucket without putting something back into it. So yes, you might need a 15-minute nap during the day. And it's actually saying, I give myself permission to take that time to actually have that nap to recharge, and then I can do something. There may be simple adaptations to your environment that can help. One patient has a perch installed in the kitchen now, so that actually she's not standing continuously to make all the dinners. We've heard from the lady at the front about complementary therapies, relaxation, mindfulness, aromatherapy, massage. It's also quite important to have a good regular sleeping pattern. And also diet and hydration has been mentioned as well.
So we're going to move on to pruritus. Pruritus, it's not just an itch. It's not an itch when you've had a mosquito bite or you've scratched yourself. It's on a slightly bigger scale. As you can see here, we've got a couple of quotes. An itch makes it sound simple. It feels like thousands of ants crawling under your skin, prodding you with hot pokers. The other person says, nothing makes it go away. After a quick shower, it will start and spread like wildfire. And then they describe using a wire brush to try and alleviate it. And that's pretty strong, isn't it? So who's had itch? Who's had pruritus here? Okay, and who would like to share anything that you found that helps? Nobody? Oh, one person, thank you. John?
It's not so bad now as it used to be, but one thing that I found was the common one, which is after a shower. What I found helped was anticipating it and knowing that getting myself warm and dry really quickly was the thing that helped. So I sort of plan ahead and make sure I've got all my clothes ready to put on as soon as I come out of the bathroom, and that I can get myself warm and comfortable as quickly as possible once the shower's over. One other thing is that a dermatologist suggested that UV light might help, because I'd mentioned that it wasn't quite so prevalent in the summer holidays when I was sort of out and about a bit. And I did have a course of therapy at Thomas's with UV light. So that did have an improvement, so I'd recommend exploring that possibility as well.
Thank you. Somebody down here?
I'm Linda Taylor. I've had PV. I was diagnosed in 2006, and I didn't have PV. I didn't have the pruritus to begin with the first year or two, but then when it did start, it was absolutely awful. But I managed to get a referral to a dermatologist, and like John mentioned, I had the UVB phototherapy. And I was very fortunate. I had a really sympathetic dermatologist, and I had quite a lot of these treatments. To begin with, you maybe only have 15 seconds in the light box, so you're not going to experience much improvement on the basis of that, but very gradually increase the time spent in the light box up to about maybe 5 or even 6 minutes of treatment. And then I really began to feel an improvement, and I really, really thought, gosh, I've cracked this, this is so much better. At that point, I was having 2 treatments a week, and I was driving to Windsor, which was a 20-mile round trip to get to dermatology, but I kept it up for quite a long time, and I did find it hugely helpful. Like John said, having a bath or a shower was agony. And to be honest, actually, eventually I gave it up. I stopped bathing and showering for 5 years. And I made the decision, because we had a bidet and I washed my hair over the basin, to just wash myself in bits and pieces on different days. And I made my husband promise that if there was the merest whiff of BO, he was absolutely to tell me. Luckily, I never needed a ticking off in that way. And I found that worked incredibly well. It made my life more bearable, and I could sort of begin to get on with things. And then I was one of the lucky ones participating in the MAGIC study. I'm on ruxolitinib, and now I don't have PV at all. And I don't have pruritus, and I don't have very much fatigue, although I still do get tired to some extent. So that's my experience, really. If you're finding bathing and showering really, really difficult, maybe consider not doing it.
Thank you very much. That's very helpful. We're slightly running out of time, so I'm just going to whiz through. I know we've mentioned it's called PUVA, ultraviolet light treatment. there are various other methodologies that people use to help with their itch that ranges from, absolutely using different kind of fabrics, patting yourself dry after shower. Some people use hair dryers. Some people like to have a big vat of cream in the fridge so they can put cold cream on their itch because it really helps to relieve them. A cold flannel, the heat of the room, and there are obviously various medicines that we use, and starting at a very basic hay fever tablet as well. But obviously do discuss that with your doctors. How are we doing for time, Nona? We got 3 minutes. We'll just touch on night sweats as well. I'm going to hand over to Claire. Oh, no, we're not. Are we doing night sweats? Oh, I'm doing night sweats. Okay, so... Forgot my line, sorry. So, night sweats, profuse sweating at night, funnily enough, but often requiring you to change the bedding. It's not just waking up a bit hot under the duvet, it's actually the bedding is soaked, your night clothes are soaked, people report having to change the sheets. So, how many people have experienced night sweats in here? It's a few show of hands. So we've probably got time just for 2 very quick suggestions on anything that you do that you would like to share with the group that maybe somebody else can benefit from. Anyone? No? It's a bit of a difficult one. It's quite individual, actually, night sweats. Our suggestions really is trying to regulate the temperature of the room. Obviously, don't put yourself under the biggest 20,000 layers of duvets at night because, you're going to get sweaty regardless then. Some people like to use lighter bedding, and natural cotton they find is better than synthetic as well. And make sure you've got these layers of bedding that's just easier to shed off as opposed to one big thick sheet. Okay. Some people like to sleep on a towel, or you can get those terry toweling liners that you use for children's beds in case they wet the bed, and they have those, and then they could just whip them off in the night to save having to get up and change all the bed sheets as well. Some people like having a fan. And then some people suggest that they find it's easier if they reduce the stimulants at night. And I don't mean things like watching the telly, it's more like things like alcohol, chocolate, not sure I'd be too happy with that, and caffeine, and sometimes people identify that helps. We're rushing through a little bit here. Now I'm definitely going to hand over to Claire for bone pain.
So we probably don't have time to go through all of these. So if there is anyone that wants to discuss any of the other symptoms or come and speak to us, or we have some of the other nurses group here who will happily take questions or talk through symptoms with you. So bone pain, it affects some people. It's a complex sensation that's both the body and the mind. Again, mainly engage with your team, engage with your nurses, complete pain diaries, complementary therapies again can help, and analgesia. Really quick. So early satiety and weight loss obviously can be a major issue for patients, and whilst it's one of the most important things to treat the weight loss is to manage the underlying MPN, but there are still strategies that you can employ to help. So sometimes it's smaller amounts and more often, snacking through the day on the high quality nutrient dense foods, so nuts, avocado, making smoothies and soups. We often say to some of our patients, there's nothing worse than having a huge plate of food in front of you, but smaller plates with smaller amounts that you actually feel, well, I've eaten all of that plate of food. Looser clothing, referrals to dietitians, quite a lot of departments now will have a dietitian attached to them, so they will help in gaining more nutrients in smaller amounts of food. The Macmillan Cancer Group also have a good diet book where they have lots of recipes that you can use. So kind of in summary, we've covered just a few of the really physical symptoms that you can experience, but it's also important to remember that MPNs have a much wider impact on your daily lives. So we're aware that there are issues with finance, issues with perhaps work, explaining to friends and families, the psychological impact of the condition. And I think the thing that we wanted to get mostly across was actually talk to your team, talk to your nurses. We're a good source of information and a good source of support, and we want to help you live with your MPNs rather than your MPNs being your focus.